Embryology may explain some of the mysteries of colonoscopy. It's no secret to colonoscopists that the colon can be very long indeed. This 3D imager recording shows the atypical loops and angulations that form, here at the sigmoid descending colon junction, due to a descending mesocolon. The endoscopist straightens this out, but see how the splenic flexure pulls right down, because the splenic flexure is mobile on a lax phrenicocolic ligament. After further manoeuvring, later on, a deep transverse loop forms. The endoscopist would reasonably expect that pulling back would lift up the loop, but actually the splenic flexure pulls down again because of its mobility. Next, because of the total mobility of the descending colon, which can move into the midline, scope pressure pushes the colon into a reversed splenic flexure configuration. Watch it happen on the imager view. This is now 45 minutes after the particular endoscopist started this procedure. Follow the gyrations of the scope and the colon until eventually the cecum is reached. And typically of such long colons, and this is the point, the bowel can be pulled back and shortened to only 60 centimetres. This colon is clearly very mobile. Why? The explanation probably starts in embryo at around 5 to 8 weeks after conception, when the embryo is only 3 centimetres long. At this stage, the gut's starting to elongate, but as a functionless muscle tube on a midline mesentery, joined to the placenta by the yolk stalk. As the intestine elongates, the abdominal cavity is too small to hold it, and the intestine and colon push out into the umbilical hernia. This occurs between 8 to 10 weeks when the embryo is 5 centimetres long. Here is a single smooth muscle cell contracting spontaneously. Its historic time-lapse film speeded up 10 to 100 times the work of Professor Bernstock in London in 1953. He used infrared microscopy to show nerve and muscle cells developing in tissue culture. Smooth muscle cells arrange themselves in bundles. Initially, the muscle cells in the bundle contract without coordination, but gap junctions form between the muscle cells, functionless at first, but becoming electrically conductive communication channels. So the muscle bundle begins to contract as a whole, with pacemaker areas initiated by a syncytium of cells of Cajal, which control intestinal contraction waves. Glial cells, which have a supportive and nutritional function, lead the enteric nerves as they migrate into the muscle tube from the neural crest. Eventually, there will be a network of 100 million enteric neurons in the gut, synapsing with each other or connecting to smooth muscle cells. The tone, size, length and functionality of the intestinal muscle tube depend on this enteric nerve invasion and differentiation. Enteric neurons are metabolically surprisingly active, with vesicles and particles travelling in both directions. And their axons also are highly dynamic, with tips exploring actively for any suitable target with which to connect. Here, an enteric neuron is contacting a fibroblast, checking its surface for suitable contact sites. But eventually, it doesn't find what it's looking for and backs off. Whereas here, slowly, an axon makes contact with a smooth muscle cell, migrates along its surface, making neurotransmitter connections. Enteric neurons differentiate during development to produce any one of 20 different neurotransmitter substances, up to 3 or more in each neuron. In the forest of neurons, interneurons, muscle cells and cells of Cajal, macrophages scavenge around. It's an extremely complex scene, so perhaps it's not surprising that sometimes things don't work out properly. So, although at 10 weeks after conception, much of the normal small intestine and colon has been forced out into the umbilical hernia, it returns to the abdominal cavity when it's large enough, normally at about 11 weeks, when the embryo is 8 centimetres long. At this stage, the colon has lengthened and the cecum has passed down to the right iliac fossa. Perhaps because of the pressure of the bulky, fluid-filled small intestine, the colon is pushed into contact with the sides of the abdomen and, by 12 weeks, becomes invested in peritoneum in its ascending and descending parts. However, in colons where, for genetic or other reasons, there's abnormality of autonomic innervation, the intestine and colon at 10 weeks will already be less tonic, so larger and longer than normal. Because of this, the gut will remain in the umbilical hernia longer until the developing abdominal cavity is large enough to receive it. This late return into the abdomen means that a large colon misses the milestone moment for retroperitoneal fixation. So the colon retains some or all of its mesenteric mesocolon and will lifelong remain mobile and difficult for the endoscopist. What starts as a minor abnormality in embryo will, during childhood and throughout adult life, be a long and mobile colon, a nightmare for the radiologist and the endoscopist, but which is likely to give autonomic dysfunctional problems such as constipation, wind or hemorrhoids, and this is often what causes such patients to be referred for colonoscopy.